Good morning, everybody. Thank you for joining us for the Econ and Public Policy Seminar this morning. Before I introduce our speaker today, I just want to remind you of our two more talks coming up later this semester. On Wednesday, November 17th at 2 p.m., Felipe Goncalves from the from UCLA is going to be presenting Do Police Make Too Many Arrests? And in early December, on Tuesday, December 7th at 2 p.m., Catherine Dickinson from the University of Colorado Boulder is going to be presenting Environmental Justice and Oil and Gas Development in Colorado. And so today, we are lucky to have Dr. Emmanuel Nshakira-Rukundo presenting. He is currently a postdoctoral researcher at the Institute for Food and Resource Economics at the University of Bonn in Germany, and his research lies at the intersection of health and labor economics with a focus on East Africa. He also recently co-founded APADA Insights, which is a development research organization based in Kampala, Uganda. And so, Dr. Rukundo, I'll turn it over to you. And Dr. Rukundo said he would be willing to take questions throughout the presentation, so please chime in if you have questions. Go ahead, Dr. Rukundo.
Thank you very much, Professor McLaren, for this invitation. It's a pleasure for me to present at Maryland, and I look forward to the questions and comments to improve on this paper as we try to submit it in the next couple of weeks or so to a journal. I presenting work that I'm authoring with Sarah Schroeder, who is an assistant professor at Aarhus University in Denmark, and we've been working on this for the whole year, and now we are starting to presenting it in places, and we look forward to these comments. Our work is on health insurance premium changes in a low-income country, and we use Rwanda as an example where we take our case study. I'll just start with two key facts that people work better or longer, or they have better participation in labor markets when they are healthier. And health people, of course, do not work, so that's not new. And what one of the ways that health can be improved is by improving access to health through reducing financial limitations and financial barriers to accessing health, to utilizing health. And health insurance is one way to do this. So there is a lot of work in this dimension that shows that when individuals get health insurance, they tend to have varying reactions and varying interplay in the labor markets. Also, what is emerging in the last couple of years is understanding what happens when the cost of utilizing and accessing health insurance, when that cost changes, how do people then respond in the labor markets? And that's one of the issues of our focus. A lot of work in this dimension is very much American. Even when it's a very vibrant research area with a lot of research there, but also this research is varying. A lot of it shows there is not so much effect in the labor markets. Individuals continue to operate as is. When a lot of other work shows there's actual reduction in participation, specifically when it is through employer-provided health insurance, and employers tend to move this cost of premiums, cost of insurance on the workers, and they tend to hire less, and so participation reduces. There's also evidence that there is positive effects of gaining health insurance in the labor markets. Individuals are more likely to be entrepreneurial. They're more likely to free up their you could say costs of worry and costs of financial limitations, actually work more. What we see in the US is, by and large, a very mixed bag of evidence that hopefully this can get a bit more. And this is mainly from the post-affirmative care the last decade or so that this evidence has emerged. What's happening in other high-income countries, for instance, like in Germany or maybe like most of Western Europe, is that there isn't anything really on health insurance in these countries because there is state legislated health insurance where individuals do not have any say on how the premiums are allocated. Very small markets for private insurance. In terms of large health insurance programs, not as much where individuals can actually have a say can have different reactions on premiums. So this work is very much United States based. When it comes to low-income countries, a lot of low-income countries in the last couple of decades have been moving into universal health coverage and using social health insurance programs as a pathway to universal health coverage. There isn't much work in this area, and that's one of our contributions. Some of the work that is there, again, mainly focuses on when people gain health insurance and not yet on when health insurance costs and premiums change. And just to give a bit of a summary of this work, for instance, in most of it in Vietnam and Thailand, that shows by and large reduction in number of hours worked, reduction in probability of employment. In Thailand shows some increases in informal employment, but also in one paper recently in Ghana that shows individuals tend to reduce the number of hours worked over time, especially adults. So what we are interested in is using Rwanda, a small country in the, you could say, in the center of Africa, in Central Africa, that has a very large health insurance program that covers almost 90% of the population. It has, you could say, the largest health insurance program in Africa or in low-income countries by coverage of its population. And we want to look at what happened when, in 2011, the government changed the policy to remove flat premiums and introduce progressive income-based, welfare-based premiums on the population. We're interested in hours worked, and we separate hours worked in various dimensions, either agricultural, non-agricultural, wage hours, or domestic hours spent in domestic activities. A bit of a recap, we find that individuals tend to, there is not so much movement in total hours worked in the last 7 days. Instead, individuals shift their time from wage employment and non-agriculture activities and move it into agriculture activities, where it's not easy to actually monitor people's incomes. There's this kind of a movement. It's highly influenced, highly driven by women, and also there's not so much in over ages of different workers. Only in wage employment hours we see that older workers tend to reduce time more than younger workers. I give a bit of a background on this premium policy change in 2011. So in 2001, Rwanda started this pilot program of a community health insurance program in 3 of the 30 districts in the country. And within a couple of years, the government they got very good feedback about it and decided to scale it up to the whole country. So by 2008, 2009, around about 70–80% of the population were already covered by this program. One of the reasons for coverage was putting in place laws. Because of the pilot program, the first 5 years of the pilot program, there was really good enrollment and good feedback about it. And then the government passed laws that legislate everyone every citizen to be a member of this insurance program. So it moves from being a voluntary community-based health insurance program to a more state statutory social health insurance program. At the time, in the first decade, 2001, 2010, individuals paid a very low premium, very flat premium, equivalent around about $2 per person per year. Now, think about community-based health insurance programs generally charge very, very, very low premiums. They have a very narrow focus of services. They are mainly for primary health services, getting malaria treatment, getting immunization, and other kinds of primary services. So not a lot of coverage for tertiary services like high-level surgeries or anything close to that. So just to position us, don't think of it as some kind of private health insurance program that charges a very high premium. But also the government subsidizes quite a lot of it. And the government also used this program to, if you know about, for instance, Global Fund for AIDS, tuberculosis, and malaria, that channels a lot of money into low-income countries' health systems. What the government of Rwanda did with the Global Fund program was to convince donors. The Global Fund program provides funding for 3 diseases: AIDS, tuberculosis, and malaria. And the government of Rwanda convinced the program not to fund disease care, but to fund the health system. And so about 60 to 80% of Global Fund money went into subsidizing the health insurance program in enabling people to enroll. So over time, the government has been started thinking about what might be the challenges for this program. Is sustainability. The donors are not always going to be there. Number 2, there's still a lot of people that are not insured, and this is various reasons: geography, education, and many other reasons people do not get into insurance. Number 3, there was necessity for government to really to increase local revenues to finance the program. And in 2011, the government decided to change this flat premium policy into a progressive policy, a progressive premium system. So you have the whole country divided into 4 socioeconomic groups, and these socioeconomic groups are assessed through a community-based poverty mapping system, poverty mapping process. Every 2 to 3 years, all villages in Rwanda, through village leaders, gather together and rank in every individual in the village per asset holding, education status, and other indicators. This ranking generates individuals allocates individuals into 1 to 4. 1 is the poorest and 4 is the richest. So what this program then does is the government of Rwanda uses this ranking to provide virtually all social protection programs in Rwanda: cash transfers, high school scholarships, including health insurance premiums. When a household is in category 1, so what I'm showing in table 1, before the policy change, this is in column 3, you can see everyone pays 1,000 Rwanda francs, for every individual pays 1,000 Rwanda francs. Post-reform, individuals in category 1 get a premium waiver, so they pay 0. The government subsidizes their insurance premiums to 0. They are automatically enrolled. Individuals in the second and third groups, so group 2 and group 3, their premiums increase by 200%, from 1,000 Rwanda francs to 3,000 Rwanda francs. Individuals in category 4, their premiums increase by 600%, from 1,000 Rwanda francs to 7,000 Rwanda francs. You might ask yourself, what does this kind of premium increase mean on a average random household in Rwanda? So at the time in 2010, so 2010 is where our baseline is. So 2010, 40% of the population in Rwanda are below the poverty line. And the poverty line is this premium increase. The average household in Rwanda is around about 4.8 individuals. 4.8 individuals, each individual paying 3,000 Rwanda francs. This is equivalent to around about 10% of the poverty line of the average poor household in Rwanda. So it's not an ignorable increase in premiums. It constitutes a lot of household budget consumption budget. A bit of a snapshot on how insurance then has progressed in Rwanda, just showing tables summarized from four surveys, 2005 to 2016. You can see a lot of poor people in, this is some kind of socioeconomic quintile. The enrollment increases, doubles over the 10-year period. Individuals again, poor individuals in quintile 2 also doubles. Rich individuals, it also increases, but I want us to kind of focus on this area between quintile 4 and quintile 5, and specifically from 2010 and 2016. So what I'm going to then show you later is the policy change happens in 2011, and so 2010 is our baseline, and our baseline, we have 84% of people in quintile 4, 74% of people in quintile 4 and quintile 5, 84%. They're enrolled. 1 year, 2 years after the policy change, there's been a large drop from 74%, 73%. This one drops by around about 12, something between 12 and 14%. It doesn't pick up much. It doesn't pick up even higher. Still remains in 2016. These individuals in quintile 5, who are the richest in the community, still remain lower than the 2010 levels. So then what we're going to look at is specific for individuals who received a premium increase. So just coming back to here, individuals in category 1, we don't consider them in this case. They get a premium waiver. Our focus is individuals who are in categories 2 and 3 who get this 200 to 600% premium increase. So what we have here is just a bit of a schema on how this policy change happened. So pre-2010, individuals are paying a flat rate. In 2011, there's a policy change, and this policy change, we can separate the population into 2 groups of individuals who get a premium increase. We have individuals who are always high socioeconomic status, who are enrolled in insurance, and because they're enrolled, their premiums increase. The next year, they have to pay 200% more after 2011. Individuals who, and these are the ones who are quote unquote treated. Individuals who are similar to these ones, who are higher socioeconomic status individuals, but who are not enrolled in insurance for any reason, they're not enrolled, and these are always going to be our control group. Now, uninsured individuals all the time, it's been, the proportion has been reducing. 2005, there are 56% not enrolled. In 2016, we have about 1/4 of the population not enrolled. So these are going to be, in 2010, we have 28% and 26% who are our control group in each of these assessments. Yeah. Any questions so far? So I can get into the kind of theoretical thinking. All right. We want to use a model by Emmanuel says and has been used in health insurance studies by Julie Shi, assessing effect of premium subsidies on affirmative care in the US. And here we can provide the first simple utility function of an individual that is based on their income minus the ability to work plus the wages they get from their ability to work in terms of the labor effort and the ability to exert that labor effort. Now, income in this case, it's determined by one, the wages they get, and plus the transfer. If the transfer is a positive transfer, income increases. If the transfer is a negative transfer, income reduces. And then individuals then, this kind of transfer can take two dimensions. One, if this transfer is based on a certain threshold. If they have, because the transfer is targeted to individuals below a certain income threshold, if an individual has is below this kind of threshold, they get a positive transfer, which is a subsidy in this case. If they're above this income threshold, they get a negative transfer, which is a premium increase that we can take as a penalty. And this penalty reduces their household budget. And so then their expected utility will be the wages derived from their labor, plus the difference of the transfer when it's positive and the transfer when it's negative. And in this case, then this would give us the kind of first order condition to see at what is the total expected utility, what is the total expected welfare of this individual. From this kind of postulation, we can make two main predictions. One is that when this transfer is positive or negative, whichever dimension the transfer is, individuals will have certain kind of behavior responses on labor effort, given that the transfer is tied on at which point of the threshold they are on, whether they're above the threshold or below the threshold. And what happens, individuals always want to come to the threshold in order to gain a positive transfer. Now, in any case, for a policy planner and social planner, the success of this kind of program will depend on how much individuals can manipulate the system. If individuals know where the threshold is, then they always want to try and be below the threshold. And so the paper by Julie Shee shows this very well in the US, that individuals who are very close to the premium subsidy threshold in the US for the ACA premiums, they tend to manipulate their incomes so not to go above the threshold. If they go above the threshold, then they pay higher premiums. They stay right on the threshold in order to continue benefiting from these subsidies. And this is what we kind of try and test and see whether it is also similar in a low-income country. So we will use data from three waves. 2010 that works as a baseline before the premium change, and 2013, 2016 that measure the short-term and the medium-term effects of this. Our treatment and comparison groups are individuals in high socioeconomic status all the time, and they get the treatment if they are insured, and they are in the control or comparison if they are not insured. We have three cross-sections, and because of that, we are only going to be making some statements on individuals of similar socioeconomic profiles, but not necessarily the same individuals. So these are repeated cross-sections without observing the individual transitions in and out. So we don't know whether an individual in 2010 is insured, then in 2013, they're not insured anymore, because we don't observe that individual again, but we always compare this individual in 2010 who is insured with an individual in 2010, with 2013 who is insured, and 2016 who is insured, and the control in the same manner. To continue constructing our sample, we use individuals only when they are within the labor markets, age, you could say age groups. So this is 14 to 65 years. We exclude individuals who've been in active schooling for the last 1 year. They're also excluded. And so we use 10,000 households, 11,000 households, and 12,000 households in the baseline short-term and medium-term, respectively, that continuously gives us a total sample of close to 53,000 observations. We then employ repeated cross sections with differences, and in this very short-term regression, what we're interested in is the labor market outcome of individual I in time t, and this time t can either be the short term or the medium term, and whether they are insured. Our main, of course, our main effect is on the interaction of insurance and the time damage. Now, why do we keep it as insurance here and rather not when they get the premiums? Because everyone who has insurance gets a premium increase. So there is no individual who doesn't get a premium increase when they're insured. If some individuals in other insurance programs, not necessarily this one, they don't get a premium increase, and we are going to use these ones as some kind of robustness or placebo checks later and see. And we control for various individual characteristics and household characteristics, and then we can bring in some fixed effects at month and districts and as a location and time fixed effects. We can then do this similar regression for medium-term assessment, in which we use 2016, the same regression all the time, all the terms remain the same. Two key things to take care of before we move into the results. One, we don't have pre-treatment trends, so we use only 2010 as the baseline, and then the policy change happens in 2011, so we don't have pre-2010 data. And to do that, we use matching. To account for that, we use matching to account for pre-treatment levels and not the trends. We don't have more of the trends. For robustness, we conduct a couple of placebo checks and additional alternative specifications of similar difference in difference regressions to see whether the results are more or less the same. Moving to the results, in the short term, so this table in the first panel, it shows the short-term effects between 2010, 2013. By and large, we don't see significant responses in labor allocation. We see significant responses in the medium term, and this is, you could say, when individuals know two things. One, they are paying the higher premiums, and they understand how also to work around their labor allocation in order to hide their incomes. And how do they do that? Agriculture hours increase by 1.3 hours in the week, and that's around about 7 to 8%. They reduce non-agriculture hours by close to 2 hours in the week, and that's around about another 8% or so. And then they reduce specifically wage employment hours by another 1.4 hours. In activities where there is income easily measured, income easily observed, individuals do not tend to reduce labor allocation in those activities. Instead, they move it to activities where in a subsistence economy, it's not easy to account for agricultural income. And that's what we see. We want to then look at.
I had a quick question.
Yeah.
So kind of thinking through the impacts, because part of it is with the health insurance that they get access to health care, and that should have an impact on their labor supply in different ways. But also that the health insurance, it's just kind of like a, the subsidy is like a lump sum transfer. So they're also just going to be changing their labor supply in order to get access to the better subsidy. So I'm just trying to think through about which pathway is more likely and whether you're able to separate the two.
Yeah, so we do not use here the whole, so what we do here is we don't use individuals who get, who already receiving a subsidy. We're only focusing on individuals who get a premium increase. So our quote unquote treatment is individuals who get a premium increase, and the control are similar individuals of the same socioeconomic status, but who are not insured and so are in the control. They do not get a premium. They are not insured in any case.
And are they, because by changing their work or their wage hours, for example, does that not influence the premium subsidy the premium that they pay, or is this set prior to their choices about wages, about labor supply?
Well, it's set prior to their choices. They can only gain benefit once every 2 to 3 years, when this kind of categorization happens again, on when they have which kind of economic class they are classified in. And essentially, this is then what we're observing with when their reduction of labor in these easily monitored economic activities, then it's more likely that in the next categorization, they are closer to the threshold.
Exactly. And so that's what I was wondering, is whether we think these effects are driven by the health insurance itself, or the desire to want to end up to appear to be in a lower socioeconomic status so that you get access to health insurance, the bigger subsidy.
We have regressions for the effect of health insurance, irrespective of without considering premium increases. I think it might not be easy to disentangle this effect, given that individuals who get insured get a higher premium. So we can't see the difference between individuals who get insured and retain a lower premium, and individuals who get insured and get a higher premium. So because these are always intertwined.
Yeah.
Yeah.
Thanks.
Yeah. So in terms of these kinds of effects by gender, we see within agricultural hours that women tend to increase agricultural hours more significantly than men. Men effect is not significant and very small in any case, only 0.8 hours with not close to any significant levels. Women increase this agriculture time by 1.6 hours. Regarding non-agriculture hours, women, again, they are the ones who mainly shift their time from wage activities, non-agriculture activities, into agriculture activities. Men tend to have a negative coefficient, but not that significant.
I would like to clarify, I probably missed this. Is this healthcare coverage, is it family or individual? Because you're separating men and women. I was wondering if the coverage is for families or is it for individuals, it sounds like.
Yeah, it's for individuals.
Okay.
So in the controls, we include the control of partial health insurance, where so this socioeconomic classification is a household classification, but insurance premiums are individual premiums. Within a household, you can observe individuals who are insured and others who are not insured, and so we some households can be fully insured when everyone is insured and others not. So we have a dummy to capture situations where households are partially insured or partially fully insured. So this is an individual level assessment. So I think at the end of the presentation, I have a couple of other classifications or heterogeneities with age and with location of rural and urban. So we'll probably come to those ones later. Now, trying to see whether our results can actually stand different tests of robustness. So we do two things. One is that we create various, we create two fake treatments, and we also conduct alternative specifications. So two fake treatments we do. The first one is we know individuals who are getting a premium increase. Rich individuals who have health insurance get a premium increase. We're always comparing them with rich individuals who do not have health insurance. So one could say, of course, rich people, they can work more. And so rich people are the ones who can have exert more hours of labor. They have probably more ability to do that. So we then use, in this first fake treatment, we use individuals who are rich and with no insurance as a treatment, and compare them with the control of individuals who are poor and don't have insurance, to see whether the movement in hours worked, movement in labor location is driven by just socioeconomic status. And again, the top panel is for short term, the lower panel is for the medium term. We see that the lower panel, we don't see any differences across rich and poor who do not have insurance, and so there is no recognizable difference at any significant levels. In the upper panel of the short term, we see some significant results. However, these in any case do not really mean much, given that the upper panel in our main effect, in our main regression, doesn't show any much effect. Two things we should be expecting with this kind of placebo. One is that if it has to stand, it has to be in the same direction as the main treatment, as a primary treatment. If it's in the opposite direction, then we could say, yeah, it has an effect. There is an effect that is we are not accounting for, but that effect is not premium increase. So what then we observe here is that, for instance, in the short term, if we look at the short term assessment, there is a positive coefficient on domestic hours, even when it's, you could say, meaningless. And here in our main regression, our primary regression, there is a negative term on domestic hours, meaning something else drives domestic hours, not necessarily the premium increases. And then we do a second fake treatment. Now, the second fake treatment, we then use individuals who have private health insurance. All along, we are talking about state health insurance program. There is 5% of the people in Rwanda who are employed and have employer-provided health insurance, or who are working in the army or the police or any other security services, and they have the government health insurance program for individuals in these kinds of services. Their premiums do not increase based on this policy, and so the assumption is that their premiums stay the same. We use these ones as a treatment to see if anything happened between these and the control. Now, the control here is high socioeconomic status individuals, rich individuals who do not have insurance. Again, we don't see any significant effects on that assessment. So with these kinds of fake treatments, we are more or less comfortable that our assessment is robust to when we use various fake treatments. We do then 2 additional robustness check. We use other difference in difference estimators. I should have said that our main difference in difference regressions are assessed through the recent Callaway and Santana estimators, which are doubly robust. And at first we were using our conventional diff in diffs, and yeah, these 2 papers have come out this year and changed everything we do. So we use the most recent, and we have this result. So we said, okay, let's use the usual ones we always use. So one was the
I should interrupt and just say, for anyone who isn't familiar, there's been this kind of methodological revolution with differences methodologies that's happened over the past few months. And everybody's been kind of scrambling to update their methodologies. So I commend you, Emmanuel. It's on my to-do list for a couple of my papers. So great work for introducing that. But yeah, in economics, the methods are changing all the time. And we just had this big push forward. So that I'm so glad to hear that. Thank you.
Yeah. The good thing with this community, they're releasing very new stuff with already the software to implement it. So very lucky that this software is existing, and then we can use it. So this is what we had in our earlier methods using kernel-based matching estimator, and we were seeing similar results that individuals tend to reduce wage hours, tend to reduce non-agriculture hours, and tend to move this time to agriculture activities. So we this kind of new methods still, if they're not any better, they are consistent with all methods in a way. But also 2 things to remember here in this kind of additional alternative specification. What we do is this difference with matching estimators, we are always matching only on the baseline. The follow-up rounds essentially don't match. In other words, we only match on pre-treatment levels, and then not the post-treatment levels and trends. So there is a very nice new paper by Avian and Van der Stellert, and which says it's always better to do matching in each round, so that you have a clear comparison in each round. And this actually also, you could say, speaks very well to another challenge with differences repeated cross sections about regression to the mean. So when you match in each round, then you actually control regression to the mean, because the mean doesn't open up in the next round. So what we do, we use the old maxima minima, creating the overlaps, and in these overlaps, we then create inverse probability weights in each round, and plug in these inverse probability weights in each round as within a weighted least squares regression. And once we do that, we get really more or less consistent results that we had in the main estimator. Maybe the only difference again here is that we also see that the individuals tend to reduce domestic hours, also reducing domestic hours. Unfortunately, we do not have, the data does not show us time spent on leisure, but we can somehow say, where if individuals are generally not increasing their time, where do they put all this time? Okay, they can reduce wage by 2 and non-agriculture by 1.6, domestic by half an hour, where are they putting this time? In any case, they seem to be enjoying a little bit some leisure, but this leisure is mainly because they don't want to make more money to pay higher premiums. So that kind of plugs into that thinking. So closing the talk, we assess the medium term, the short and medium term labor allocation as due to changing in premium health insurance premiums in Rwanda. One comment to make is, why do individuals feel how are they incentivized to always try to be close to the threshold? And this is the whole theory of Emmanuel says about bunching on the thresholds, bunching on the margins. In this case, bunching is happening because of the targeting that is being the targeting method. So Rwanda uses a community-based targeting for its poverty assessment, and this community-based targeting is then taken up by the government for all social protection programs in the country. And what happened is, I think in the paper, we make a comment on that. But then what has happened between 2001 and 2010, Rwanda's poverty reduced by a massive almost 20%. Between 2010 and 2020, poverty in Rwanda reduced by only 0.9%. There's been a stalling of poverty in Rwanda, a stalling of poverty reduction in Rwanda. Why is this happening? The government is coming to this realization that they're using a really bad targeting method to allocate social transfers. And in 2020, in December 2020, the Minister of Finance in Rwanda announced that they are not going to use this method anymore to allocate these social transfers. So this is kind of, you could say, in tandem with the policy realization of what's happening in the country, that they realize, in our case, we are assessing health insurance, premium waivers. Another person is going to assess education scholarships or cash transfers or anything else. Any other method, any other social transfer, any other social program that is using this targeting method is having similar results, that individuals tend to bunch on these thresholds. So our paper generally speaks to two things. One, increase in health insurance premiums. Two, effects of bad targeting and the unintended effects of bad targeting. And I think that's what we can observe in this case. I think after here there is a couple of other slides, so that are more or less not very central to the conversation at the moment, but some of them will come up in other. Thank you so much for this for your audience.
Thanks so much, Emmanuel. Does anybody have any questions for Dr. Rukundo? And graduate students, feel free if you want to send me a private chat if you don't want to speak up, but I'm happy to take questions.
One general set of questions I had sort of all along is this sort of this issue about classification of people into, and this is sort of central to what you're doing, these incentives for people not to appear in high SES groups. And I'm just wondering in general how, I don't know who's doing this, doing the classification and measurement, but just how well they can even sort of gather the information to do it, and whether, like in your hours things, whether there's a lot of hours going on that aren't really being measured. This whole issue of basically people being paid with cash and under the table, and so it's not really leisure, it's just that they're doing work that's not being sort of captured in measurement. I'm just wondering about that whole dimension of your study.
Yeah. Thank you very much, David. Essentially, I was a couple of months ago, I had a really long comment on this kind of targeting, and a senior professor advised me to write the political economy, a paper on the political economy of targeting in Rwanda. So two things. One, Rwanda is a very, you could say, centralized country with a lot of authority in the state, and that authority fizzles into the population very easily. And in communities have village leaders, and village leaders every 3 years or so, there is a directive from the government, okay, next week we are doing our poverty assessment mapping. And everyone, 1 month later, you need to bring your results to the district headquarters. And so communities do this by themselves, and the leaders send these results to their authorities above. So the sub-district and the district, and then the central government. So what happens, all this information is then input into a national identification database that then can then allocate these individuals in one of these 4 groups. So individuals provide the data, but they don't know which group they are in until 1 month later or so, they get communication from the government that, oh, you're in this group. So there is not so much. At the village level. There is not so much of manipulation in data provision before. It then happens in the second and third rounds, 2013 or 2015, when it's done every 3 years. Individuals provide less data. So I have 10 cows. Of course, I'm not going to say I have 10 cows. I'm going to say I have 6 cows. So if it means if I say I have 6 cows, then I can. So that's where this manipulation is happening, and that's why the government realizes, oh, all along everyone is lying to us. So maybe we are not as poor as we think we are as a country, but actually have crappy data on how we assess poverty, and that's because people are lying to us in this dimension. So that's the kind of areas where you could say the government has a very interesting goal of controlling individuals and providing data, but individuals have a very interesting goal of manipulating the government in providing crappy data.
Hi, thank you for your talk. I had appreciated very much when you mentioned the global funds being used for this community-based health insurance program rather than for HIV/AIDS and malaria, because I've been studying malaria a bit as well. And I read a report about Rwanda's malaria cases going up since 2012, whereas from 2000 to 2011, they were really reduced significantly. But the report I read never mentioned that perhaps this was because of the fund transfer going into the health insurance care program instead of going into malaria. And I wonder now, based on your talk, if that can be one of the reasons.
Yeah, I think that's a very good one. I probably would like to find that report and have it get some ideas from it. I think this could go either way. There's a lot of people in the development community who say Rwanda has done extremely well compared to other low-income countries in health access, in extension of hospital services, mainly through this health insurance program and other policies that the government has passed, performance-based financing, health insurance, and many others. I think I come from Uganda, so in Uganda there's only around about 60% of women are delivering in hospitals. In Rwanda it's close to 90%. And it's partly because of this access to care in a way. But I think I wouldn't be surprised, and the government is not surprised by these kinds of later unintended effects. Of course, moving money from AIDS, tuberculosis, and malaria into a system, there is a bit more equity. Actually, Global Fund, even in Uganda and other low-income countries, it allocates a lot of money in the health system. So there's a little bit of equity when you distribute resources across many things. That doesn't remove the problem that malaria is the highest killer in low-income countries in Uganda. So if you take money from malaria, it's definitely going to increase. So that wouldn't be a big surprise.
Other questions? Emmanuel, I was thinking, because it sounds like these thresholds, the income thresholds, are used for several different programs, and so that is going to potentially confound your estimates of the impact of health insurance. So I was trying to think about ways that you might be able to disentangle those two effects, at least with some descriptive analyses. And you talked about the bunching. Are you able to look at some of the distributions of the hours worked to see whether, because the theory tells us we should see bunching on income, but that means we should also see bunching on reporting hours worked. So wondering whether you can look at some of that bunching to try to estimate how big the bunching effect is, to kind of and to figure out. So if you can figure out how big the bunching effect is, you can do some potential simulations or back of the envelope calculations to figure out how big that bunching effect is, how big of an effect that has on your results, to try to tease out whether that can account for the full effect, whether it's really all due to bunching, or whether you can tease out the direct effect of getting health insurance. So I wondered about that bunching. I am also wondering, since you have the whole household and it's individual level insurance, that, I mean, for example, the gender difference you're getting is suggesting that, women are maybe more, it's easier for them to misreport their wage hours, maybe more if their work is under the table, for example. So trying to look at some of the demographics or characteristics in your sample to try to say, for people who are less able to misreport their income, for example, working in the formal sector, what effect do you see on them? And so just trying to tease out, even if it ends up mostly being descriptive analyses, because I think that, especially since this is a threshold that's used for many government programs, that it's not just the transfer of health insurance in terms of the monetary value of that, but it's bunching that will influence a lot of government income.
Yeah.
And so we'd be very worried that that could be a big effect, and that you're really picking up the effect of that rather than the direct effect of the health insurance, which I think influences how you interpret your results.
Yeah.
However, I do think that even if you're picking up the bunching effect, I mean, that in itself is a really important policy question to be answered. And so maybe this is a way to kind of get at that question about the value of government transfers, and the fungibility of hours reporting, even if you aren't fully able to get at the health insurance. Because I think in the health insurance literature, they're looking at situations where you're eligible, but do you get access to the health insurance or not? And it's independent of other government transfers. So working to disentangle that, I think, would really strengthen the work you have here.
Yeah, I think so the reason I'm showing this table here is just to show you which controls are included in the model, and as the household and individual controls, and we account for individual participation in other government social programs. So all government social programs are classified under this VUP, which is just a government name for all social programs. And within here, there is cash transfers, there is asset transfers, where a household can receive, like, say, one cow or so, or something like that. And then there is credit support. There's kind of various programs, all of them classified under this. Essentially, yeah, it's about 11% of the individuals who benefit from of individuals I live in households who kind of benefit from at least one of these social programs. Health insurance tends to be the lion's share of these social programs. The others are quite small in size. That's one. So we kind of account for other programs and whether these individuals are driven by not just insurance but also by other social programs in which such a targeting policy affects as well. That's one. Two, regarding yeah, I think we'll possibly get a few other regression tables on formal and informal sector. That's what we are always trying to get at here when we're trying to say wage hours, and I think wage hours actually really includes wage formal and wage informal. Quite a lot of it is formal, but also there is casual laborers who earn a wage, who report a wage every other time. I think we do some regressions on let me see. Yeah, I think they are not there, but we do regressions on lower, we could say, within the same socioeconomic classifications that are derived from this community mapping. We can still get an array of rich and poor by some kind of consumption quintiles, household consumption quintiles. And so we separate these consumption quintiles into rich households with higher consumptions per person and poor households with lower consumption per person. And we actually do not see any difference in these. We don't see any difference between rich and poor, meaning that everyone is really behaving in the same way, trying to beat the system. It's kind of not one or the other. It seems everyone kind of moves in the same direction. Yeah, I think it's in the paper in these additional tables in the appendix.
Any other questions for our presenter today? Last call for questions. Wonderful. In that case, thank you all for joining us today. Thanks to our speaker, Dr. Emmanuel Nshakira-Rukundo. And if anybody wants to stick around to chat with the speaker, feel free to do that. And otherwise, have a wonderful afternoon, everybody.
Thank you so much, everybody. It's a pleasure presenting to you, and I think some of you here have read your papers, and finally talking to someone who read their paper. That's really fantastic for me. So thank you so much for your time.
Thanks, everybody.